Hi, and welcome to an in-service on hypertension in pregnancy and postpartum. My name is Donna Grothwell, and I've been a nurse here at Elkhart General for 36 years, all in maternity services. I also work for Southwestern Michigan College and in their nursing department, and I do clinicals in OB and some other teaching with them. So I do have a love for teaching, and I hope you'll find this informational. I'm going to try and go through it pretty fast because I know how valuable your time is. There's a few different reasons why I put this in service together. First being that as a hospital, as providers of care to patients who come into our hospital, we of course want to give the best possible care. We want to give care that is evidence-based. We want to give care that are standards of care. And we are utilizing some protocols that we are expected to use as a hospital. Organizations like JCO want to make sure that we are following those standards. So I thought it might be a good idea to talk about some of these things. So starting off, the definition of maternal mortality is the death of a woman while pregnant or within 42 days at the end of her pregnancy. It doesn't matter how long that pregnancy lasted. It could have lasted 10 weeks. It could have lasted 41 weeks. And they're looking at deaths that occurred from any cause related to or aggravated by the woman's pregnancy or its management, but they're not looking at accidental or incidental causes. And the mortality rate is calculated as the number of maternal deaths per 100,000 live births. So this is a graph that shows the developed countries of the world. And, first off, that red line that's connected to the United States shows how our numbers have gradually and continually increased over the years, whereas other developed countries in the world, their numbers have gone down. So if we just look at the United States, you can see 3 states that are darker red in appearance, and Indiana is one of them. And these are the 3 highest states of maternal mortality in our country. The state of Georgia, I believe, is first, Louisiana is second, and we're number 3. And that's not a place that, of course, we want to be. If you go to the far western side of the country, you can see that California and Nevada they're in the white, so they have the fewest amount of deaths. Talking more about Indiana, this compares the whole of the United States and shows what the rate is for us as a country compared to Indiana alone. And you can see that the rate is probably twice as high as the United States. And this was back in 2016. So this is the last graph I'm going to show you, and it shows the trends between California and the United States as a whole. So the blue line is California and the red line is the United States. And you can see in 2006 where California spiked up to 16.9. And so at that point, the state realized they had a problem and they wanted to fix it. And they spent a lot of time and money and energy on developing protocols. This mainly went through Stanford University. And what they did is they looked at the hospitals in the state, at their rates, who did good, who did bad, or I shouldn't say bad, but lower when it came to maternal mortality rates. And they developed protocols with using evidence-based guidelines and put together protocols that are now used across the state. and everybody is doing the same thing in the same amount of time. And they've managed to bring their, as of 2013, it went up just a tiny bit to 7.3, and those numbers have not gone back up again. So throughout the United States, then, hospitals are using their protocols and putting their protocols into place so that they can develop some of these better numbers. And it's expected that we do that. JCO looks at our protocols, and we're following the same ones. And of course, places that the hospital has to turn statistics in on, they have to, show numbers and mortality rates and that kind of thing. So there are groups of women based on their race, based on their socioeconomic status, their age, who are at higher risk for maternal morbidity and mortality. That would include the African American women, who are 3 to 4 times more likely to suffer than Caucasian women do. Women who live in lower SES or lower middle class are more likely to have morbidity and mortality during childbirth and postpartum. Young adolescents are at the highest risk of fatal complications of any age group, and non-English speaking women also have a greater chance of M&M during childbirth or postpartum. And as you know, we see all of these women in our hospital every day. And so even more of a chance then to be aware of their risk and what we can do to help. For the mom, there are certainly some pretty dire complications that can happen during pregnancy. They can have a placental abruption, which leads to blood loss, and depending on the size of the abruption, their baby suffers from that and can die from that. They can have DIC, cerebral hemorrhages, strokes. They can have liver failure, renal failure. It can affect their cardiac system. And not just now, but studies are starting to show that they can get more cardiac issues later in their life. They're 4 times more likely to have a stroke while they have this complication or later in their life. And of every 4 women who die overall during pregnancy, labor, or postpartum die from complications of preeclampsia or eclampsia. There are several different classifications of hypertension. So different women have different types of hypertension. It's based on the gestational age at the onset of the hypertension or the presence or absence of other symptoms. So the first one, which is what we probably see the most, is gestational hypertension. Used to be called PIH or pregnancy-induced hypertension, but now is known as gestational hypertension. And this is a hypertension that's noted to begin after 20 weeks of pregnancy. Before that, their blood pressure had been normal. And it's without any proteinuria or other or severe features that you'll see here on another slide. 25% of these patients will go on to develop preeclampsia. So number 2 is divided into A and B, but preeclampsia is a new onset hypertension after 20 weeks of pregnancy. Prior to that, their blood pressures were good. It can occur up to 6 weeks postpartum, whereas the gestational hypertension usually ends soon after delivery. What makes it different is that it's a hypertension with proteinuria, or it's a hypertension with one or more of the severe features that are listed. Thrombocytopenia, platelets less than 100,000, impaired liver function, increased serum creatinine, pulmonary edema, or a new onset of cerebral or visual disturbances. So 2B then is eclampsia, which is everything we talked about when it comes to preeclampsia, but the big difference is that they have a grand mal seizure with no prior neurologic problems. 50% of these seizures can occur in the antepartum period before they deliver, and 50% of them occur in the postpartum period. And of those 50%, 16% of those will happen later than 2 days after delivery. The third type is chronic hypertension, and these are patients who had higher blood pressure before they were pregnancy or prior to 20 weeks of gestation. And this hypertension will persist beyond the 12 weeks, postpartum. They are at an increased chance of developing preeclampsia, and their pregnancy is at risk for placental abruptions. And then number 4 is the patient who has chronic hypertension, and then they have superimposed preeclampsia associated with their pregnancy. So they develop the proteinuria, the severe features that were listed, and these patients can become quite sick. So another variant of preeclampsia is called the HELP syndrome. So 5 to 10% of women with preeclampsia can go on to develop the HELP syndrome. It is a complication, of course, of preeclampsia or eclampsia, and it can involve multi-organs and can cause a lot of damage. Morbidity and mortality with HELP is associated with DIC, pulmonary edema, renal failure, and stroke. These patients need immediate treatment. Now, the HELP, the name of HELP tells you, what we're looking for. If they have these things, then they have HELP syndrome. So the H is for hemolysis of the RBCs. You can see burst cells or schistocytes. They also have elevated liver enzymes, the SGOT and PT, and they have the low platelets, less than 100,000. Problem with HELP is that the signs and symptoms are pretty nonspecific. They could present with flu symptoms, just being tired. They may have epigastric pain, and when they do have epigastric pain, it means there's some severe liver involvement going on, and their blood pressure may just be mildly elevated. So, these patients are not real easy in letting us know what's going on with them. And sometimes these patients, you might just think, oh, they're tired from being pregnant. Pregnant patients have nausea and vomiting, but that's what makes this syndrome hard. So the cell damage leads to fibrin deposits, and platelets adhere to those fibrin deposits in the blood vessels. Those red blood cells are damaged. They pass through very narrow blood vessels and become hemolyzed. And so the RBC and platelet counts decrease, which may then lead to hyperbilirubinemia. So there are some normal pregnancy changes that we expect to occur. There's systemic vasodilation. There's an increase in plasma volume by sometimes up to 50% more blood in their system versus what they had when they weren't pregnancy. That does increase their red cells, so that will give them a higher hematocrit. There is hemodilution going on. They develop a physiologic anemia, so a decrease in their hemoglobin. Their cardiac output, stroke volume, heart rate, and O2 consumption will increase. And there's a decrease in the systemic vascular resistance and a decrease then in blood pressure. Other than that, you can see that their fibrinolytic activity has decreased, and then you can see what stays normal. And it's normal for women to have some peripheral edema during pregnancy. So in contrast then, women with preeclampsia have a smaller increase in blood volume. The plasma volume sees little to no change, so they're hemoconcentrated. They have an increase in peripheral vascular resistance and vasospasms. Their fibrinolytic activity increases, their platelet counts decrease, bleeding time is prolonged, and that's why they get into some coagulation problems. Now, I haven't talked much about why women get preeclampsia, and that's because, there's, as long as I can remember, they've been trying to figure out what causes this. But one of the things they do know is at the time of conception, when the placenta is forming and it takes over the role of providing baby with the oxygen and nutrients, it's at that point when the placenta actually implants into the uterus is when the predetermination is made as to whether this pregnancy has preeclampsia or not. And so what researchers are trying to do is to find biomarkers that can be tested for in early pregnancy so that, it can become a normal part of their prenatal care, and they can more closely watch the pregnancy along with watching the baby, because these babies tend to not grow like they should. They have intrauterine growth restriction. They may end up with where the blood isn't getting to them, the oxygen isn't getting to them, and they can, die during pregnancy or have some severe problems. They're usually born premature because the pregnancy needs to, be delivered, so they induce them or whatever. So hopefully someday that will happen, so that we can find out a little sooner. So hypertension affects all the organ systems, the kidneys, the central nervous system, the liver. Hematologically, it affects that, and affects the cardiovascular and pulmonary system. But some of the systems that we watch really closely is, first of all, their renal system. It will reduce their kidney function. We're looking for protein in their urine, and that is captured in a 24-hour urine, and over 300, if they're at 300 or more milligrams per liter of urine, then they have proteinuria. A faster test that we use here in the hospital, because of course there are times you can't wait for over 24 hours to get results, is called the urine protein creatinine ratio. This is a newer test that we've used over the past couple of years. We send a urine specimen to the lab, and we get those results within an hour or so. And so if it shows 0.3 milligrams per deciliter or greater, then they're diagnosed with proteinuria. Can use dipsticks. We do use dipsticks. The problem with them is they're not as reliable because at different times of the day, women naturally have different levels of protein in their urine. So can use them, but they're not the best way to diagnose proteinuria. So labs that we do are the BUN to look at their creatinine. We also look at the uric acid. There is increased central nervous system irritability. We see that in the woman who has a headache, who is hyperreflexic, has clonus, has an alteration in their level of consciousness, or they have seizure activity, and that's due to cerebral edema or hemorrhage, and of course have the increase then in intracranial pressure. Liver-wise, it can cause a lot of problems. It can get bad enough that they can have a liver rupture, go on to develop that HELP syndrome. And so we keep an eye on their liver enzymes through the CMP. We're also looking at their platelet count. If it's under 100,000, then that's a big red flag for us. There also can be destruction of the platelets and destruction of the red blood cells. So they always get a CBC, and if the platelets are less than 100,000, then we're going to do some clotting studies with a PT, PTT, fibrinogen, or FTP. So the vascular system, they can get thrombus formations, vasoconstriction, vasospasms, and the capillaries are easily, well, they're permeable, so that they lose water, and that contributes to even more edema formation. There's, normal edema of pregnancy, and then there's edema with pregnancy hypertension problems. So they are at risk for pulmonary edema, MIs. So as you can see, it can cause a lot of problems. So there are many risk factors that puts a woman at risk for hypertension. First pregnancies, if they're young or older. If it's a first pregnancy with a new partner, they think there's, the body sees this pregnancy differently, and so it develops or helps to intensify the hypertension. If they've had a history of preeclampsia, or if their mothers or sisters have had it. Low SES, African Americans, if they've got twins or triplets, and then you can see the different pre-existing medical factors, especially if they're obese, and if they have chronic hypertension to begin with, or if they develop diabetes during the pregnancy, or they come in with type 1 or type 2 diabetes to begin with. So when a patient presents to the emergency department postpartum, and they're postpartum, primary assessments, we want to, get a blood pressure on them, cycle those every 15 minutes. You want to hear about if, do they have a headache, description of it, how long have they had it, is this a new headache, if they've got a history of migraines, is this a different feeling headache? Usually headaches with hypertension and pregnancy are more of a frontal, but they could be, anywhere. Visually, do they have spots? Are things blurry? Does light bother their eyes? Swelling, I usually say, how does your swelling compare to yesterday? Or how does it compare to when you went home from the hospital? Epigastric pain, they don't know what that is, so you just got to point to your upper rib cage area on the right side and say, do you have any constant pain there? How long has it lasted? What kind of hypertension has she had? Is she a chronic? Does she have chronic hypertension? Was it just up during the pregnancy or labor? And when we sent them home, did they still have an elevation in their blood pressure? Were they sent home on antihypertensives? Signs that you want to pay really close attention to, because they can be signs of impending eclampsia or seizure, would be a persistent headache with blurred vision, that epigastric pain, and especially if they have an altered mental status. And, the leading causes of morbidity after a seizure are neurologic deficits and aspiration pneumonia. So when you're doing that primary assessment, the taking of the blood pressure is really important, and how you do that. Of course, we want to have a proper size cuff that covers 80% of their upper arm. If you have too small of a cuff, then we're going to get false high readings. And of course, if it's too large, then we're going to get false low readings. You want them in a semi-Fowler's position. And it used to be back in the day, we'd put them on their left side, and their blood pressures would be better, so we'd be happier. But we want them in a position that they're in a lot of the time, whether they're laying in bed or, sitting up in a chair or moving about. They need to rest 5 or 10 minutes prior to that first reading. We don't want them talking, so we ask them to not talk until we take their blood pressure. If they're sitting up, their feet needs to be on the floor and uncrossed. And what we're looking for is a blood pressure over 140 systolic and or over 90 diastolic. If we have a blood pressure that's greater than 160 and or 110 diastolic, that the blood pressure needs to be repeated within 10 minutes. And if it's still elevated, then we need an order to give an antihypertensive, and we'll talk more about that in a little bit. So a proper size cuff is so important, and just giving them a chance to rest a little bit before it's taken. And if we're at the 140 over 190, then it needs to be repeated every 15 minutes. Other signs that we're looking or asking about, I think I've mentioned already, but the edema, is it pitting? Deep tendon reflexes, we use this as more of a, to see what they are, and then we can compare future ones against this. We have a 0 for we can't, get a patellar reflex, up to 4 where we just barely touch their knee and they're kicking up. We also measure clonus. And if you're not familiar with doing this assessment, I'm sorry if you are, and I don't want to I don't want to give too much information, but I also want to give enough. But if they're laying in bed and you push their foot up, you have them raise their knee, and I usually hold their knee up, try and get them to relax. And what I'm going to do is push up on their foot, and if that foot kind of beats, it comes back down on my hand and you can feel beats of clonus, then that's clonus, and it's, 1 beat or 2 beats or whatever it is. And that's just a sign that the central nervous system is irritable. We're going to dipstick the urine for protein, which I just told you, isn't always accurate, but sometimes it's better than nothing. And then, questions we ask them. Sometimes they think that, they're having heartburn when it's more of an epigastric pain off to the right a little bit. And if you add nausea and vomiting onto that too, then they're getting sicker. Also, part of the primary assessment is to find out what went on during their pregnancy and delivery. And so finding that information is very helpful. Hopefully they've delivered at Elkhart General and records can be reviewed. And you're interested in what her blood pressures were while she was here, what her labs were, was she on max sulfate, or did she receive other meds? Was she discharged home with an antihypertensive? And sometimes they're not even taking it, or they haven't had it filled yet. And so that might be the problem right there. Physicians, will put in their notes what was going on. And if you need any help going through those records, or you need somebody at the bedside that can help you, or just have some questions, please call the maternity charge nurse, and we can help look at records and give you, as much information as we can from there. When they deliver at another hospital, or say they deliver at home, that's when it gets a whole lot harder. So you can ask the patient to give us as much of the information, but as we know, they're not great historians, and they don't know everything that, they can't, possibly be able to tell you everything that went on. But do they have chronic hypertension? Right now, does she have preeclampsia? Is she heading towards eclampsia? So then you can move on to the secondary assessment. That's the secondary assessment. Then is when we want to gather some labs, and a CBC. Of course, the H&H is helpful. Platelets, WBCs, depending on how long ago they delivered, those will probably still be elevated, and that's normal. CMP, we can look at our creatinine, BUN, and our liver enzymes, and these all need to go stat because we need to know now. You can send a urine for the protein creatinine ratio, but if she's still having vaginal bleeding, then you're going to need to do a straight cath, or if you really feel like your patient can do a true clean catch, then that can be done. But the lochia, or the bleeding from pregnancy, has a lot of protein in it to begin with, so you really don't want that in the specimen itself. Some doctors are interested in what the uric acid is, and if there's an increase, then that can be associated with renal failure. Also, that LDH. Not all doctors want that, but it is a helpful piece of information, can let you know a little bit about hemolysis. But are the platelets below 100,000? And if they are, then those clotting studies need to be done. So there are some criteria that we go by, and there are some protocols that we go by. And the National Partnership for Maternal Safety was created to facilitate an urgent bedside evaluation and escalation in care for pregnant women, and it's known as MUSE. And I'm going to show you the tool here in a little bit, but there is a tool called the Preeclampsia Early Recognition tool that triggers what needs to be done, what assessments need to be done, what consultations need to be done, and what treatments need to be given. And the aim is to standardize care and provide treatment within a needed period of time. So it was difficult to get this into one slide, but you can see the things that are being assessed on the left, whether it be vital signs, whether they are alert and oriented, do they have a headache, do they have pain in their abdomen or chest. There is a fetal signs category if they're still pregnant, and that would be up to us to do a monitor on them. And then you can see more labs and their urine output. And it's divided into green, yellow, or red, so you look at each thing and see where it falls. And like under severe, if their blood pressures are greater than or equal to 160 over greater than or equal to 105, and remember, those numbers don't have to both be elevated. It just if one is elevated, and if their heart rate's greater than or equal to 130. So it tells you that these are severe signs versus worrisome signs and normal signs. So this is the bottom of the tool that I wasn't able to get into that first slide. And it tells you what needs to be done based on what your findings are. So under yellow, the physician needs to be notified. They need to do an in-person evaluation. The charge nurse needs to be made aware so that she can help with this care. Labs need to be done. We would call our anesthesia provider and consider mag sulfate and give them some supplemental oxygen. Under red, of course, you can see a whole lot of things that need to be done. They need to be a 1-to-1 patient care ratio, and they might need a CT right away. They may need medications. They just need a whole lot more at this point. And I'll make sure that your educator has a copy of this tool. So our MUSE protocol at Elkhart General in our department, and I assume in other places also, is that action is required when any of these MUSE criteria are met. And so anything in red needs to be communicated to the provider immediately. And then anything in black that you come up with, whether there's, if their systolic is less than 90, say we have a patient who's bleeding, or it's 160 or greater, and so on, we need to wait 10 minutes do these same evaluation again of their blood pressure or vital signs, and then if they still are in this category, or they, their diastolic BP is still greater than 105, then we need to call a provider and get some orders based on those results. So the drug of choice in the management of preeclampsia to prevent seizures is magnesium sulfate. It depresses the central nervous system irritability, and it decreases the smooth muscle contractility, not only of the central nervous system, but of other organs in the body also. It can slow respirations, it can decrease urine output. And it's almost exclusively excreted through the kidneys, so they can become mag toxic if the kidneys are impaired in any way. So we'll do mag levels, and I know, this type of patient you're not going to have in the ER forever, but we will do them every 6 hours or more often if they're showing some signs of toxicity. So we keep a gram of calcium gluconate handy. We keep it in the room because if we do get into some toxicity problems or the patient is showing decreased respirations, then we'll give this antagonist. And this, the ISMP does list mag sulfate as a high alert medication and requires one-to-one nursing while initiating or until they're stable. A loading dose is given of 4 to 6 grams, and it depends on how sick they are as to whether we give 4 or 6. But the pharmacy has pre-mixed bags of both of these, and we give it over 30 minutes. And then we do a maintenance dose from that point of 1 to 2 grams per hour. Usually we'll start with 2 grams an hour, and it's 1,000 cc's of lactated ringers with 20 grams of mag. And so we usually run that at 50 cc's an hour if it's 1 gram, or 100 cc's if it's 2 grams. They should have a primary IV of normal saline or lactated ringers, and then the mag is a secondary IV into the lowest port. It's not a piggyback. And both of these IVs need to go on pumps. And we also use a burette so that there is no possible way that, if something would happen to the pump or somebody plays with it or whatever, we can't accidentally, infuse 500 cc's. The burette, will prevent that from happening. We do as per policy, we do a double check with another nurse to confirm the dose at initiation and when the dose changes and at the change of shift. Because we don't want to overload them with fluids, we usually maintain a fluid balance to decrease the chance of pulmonary edema, and usually it's around 125 cc's per hour between both IVs and oral fluids also. Those are some signs of mag toxicity. Their level of consciousness will decrease. They can actually go into cardiac arrest, and if the respirations are less than 12. When we do a loading dose, the normal side effects that they feel are normal. They feel really warm, they are flushed, they can get diaphoretic, and their speech might be slurred a little bit. Patients who are receiving mag, up to the point that you would transfer them to our floor, is that they need blood pressures done every 15 minutes. They, every hour at least, need their DTRs and clonus evaluated, their respiratory rate, their heart rate, what their urine output is, and we'll usually put a Foley in so that we can measure accurately how much urine they are putting out, unless they're putting out a bunch to begin with. We're going to listen to their lungs, make sure they're not going into pulmonary edema, and what is their LOC. They should be in a dark, quiet environment with the side rails up, and we'll put padding on the side rails just in case they have a seizure. If they happen to be pregnant, we're going to be doing continuous monitoring because the baby does get the effects of the MAG. And if they're delivered and say they bring their baby in with them, it is okay for them to breastfeed while they're getting MAG. So this is one of the protocols that we use, and this is antihypertensive medications and how to give them, when to give them, how much to give them. And these would be patients with blood pressures at 160 and over equal to or greater than 105. And if we have two of those within 15 minutes, then this is where we move next. And through the middle, you can see the labetalol piece of it, and to the right is hydralazine. But if we go to the middle, it says labetalol 20 milligrams IV push over 2 minutes. BPs need to be done Q5 minutes, and cardiac monitoring is required. If after another 10 minutes the blood pressure is still over that threshold, then we would give 40, and then we would give 80. And if after 10 minutes the blood pressure is still over the threshold, then we would move to the hydralazine section. And you can see it's given about every 20 minutes, and it starts at 5 milligrams, goes to 10, another 10, and so if this was the first drug we tried and it still wasn't working, then we would go to labetalol. But usually one of those does the trick. On the left-hand side, it talks about procardia, and it talks about if there's no IV access and BP is still above the threshold, then we can give 10 milligrams, and then 10 minutes later, if it's still high, then we can give another 20 milligrams, and after 20 minutes after that, we can give another 20 milligrams. And then at the bottom, it already talks about if they've had a seizure and they've been on MAG, then we're going to give them another bolus. So a little bit more information about the antihypertensives. The med should be given within 30 to 60 minutes after that second reading of blood pressure, and we're trying to prevent a stroke. If they don't have severe features like the platelets less than 100 and so on, their liver enzymes are okay. If all those things are okay, then we're not going to hit them with all these meds. We may just give them labetalol PO or procardia PO, or sometimes both. They work together also. So our aim, especially with pregnant women, is to not lower them a significant amount, but down to the 140 to 150 over 90 to 100 range. If she's still pregnant, a real decrease in pressure can cause an abruption. The first line meds, like I said, we use our labetalol and apresilene, and then the PO procardia if no IV access. Labetalol is contraindicated with asthma. It does have less side effects than the apresilene. The apresilene is a vasodilator, and you can see all the different side effects that they may have with that. Procardia is available in both an immediate release and a release over time, and we would want the immediate release. Some of the obstetricians give labetalol during pregnancy, and then other physicians don't do this because they say it can mask some of the signs of preeclampsia. But all OBs usually will send a patient home on labetalol if their blood pressures are still up. And I already said that sometimes we have to do both labetalol and procardia. So this is the end of my presentation. I realize that you're not going to have patients down there for a significant amount of time, and sometimes they may be there longer than you want them to be, but it's important to keep up on the blood pressures and treating the high blood pressures as needed. But I appreciate your time. I know you're busy, and I hope you found this information helpful. If you have any questions, please feel free to send me an email. And again, thank you.